All right. In the interest of time, I think we're going to go ahead and get started. Good afternoon. My name is Akeem Demahan. I'm Senior Director for Quality and Patient Safety Policy at the American Hospital Association, and I have the privilege of moderating this afternoon's session on the power of data. And we have four panelists to talk to us this afternoon, and they represent really a breadth of experience and diversity from both the public and private sector. So just a couple of logistical details. To make sure that we have enough time to get through all of the material this afternoon and allow time for questions, we're going to have each of our panelists go through their presentations first. And then we'll do a Q&A session at the conclusion of that. And each of them is going to come up here and give their overview presentation. Just to give you a sense of who you will be hearing from, and in the interest of time, I'm not going to read through their full bios, but I will point you to the conference website that includes bios of all of the speakers that are featured at the sessions today and tomorrow. But our first speaker will be Dr. Albert Taylor, who is Medical Informatics Officer in the Office of the National Coordinator for Health IT at HHS. Our second speaker will be Lauren Ripplinger, who is the Chief Public Policy and Impact Officer for the American Health Information Management Association, or AHIMA. And then finally, we're going to hear from two folks from the CMS Office of Burden Reduction and Health Informatics, Lieutenant Commander Rena McLean and Samantha Richardson. So without further ado, let me welcome Dr. Taylor.
Great, this is my first ovation, that's good. And I think everybody can hear me okay. As Akeem said, I'm Al Taylor from the Office of National Coordinator, and I want to talk a little bit today about USCDI and how USCDI can help with interoperability of health equity data. First, a little bit about USCDI, and then we'll talk about the process that we use to update USCDI, and then how certain of the data elements, certain of the components of USCDI can help advance health equity and the mobility of those data. And then talk just briefly about how, as one of our roles, how ONC coordinates with CMS and other federal agencies to advance not only health equity data, but data in general. USCDI was introduced in 2000, and it was part of our fourth certification criteria edition that was published as part of the ONC Cures Act final rule. What USCDI does is define the set of data that are required to be included in these listed exchange mechanisms, and these are structured documents with a certain amount of content, and that content is defined by USCDI. And so these are including things like transitions to care documents, electronic case reporting, and or create a meaningful machine readable consolidated clinical document architect document. For those who have downloaded their record, you may have downloaded a CCDA document with all of your information in it. And then the last one actually represents two different certification criteria or functional criteria for certified health IT, and that is to enables the access to your data through what we call application programming interfaces using the HL7 FHIR standard. And so within that, there's a defined set of content, and that defined set of content are the data elements that are in USCDI. And so as we add new data elements to USCDI, we add to the amount of information that can be exchanged. You don't have to read this whole slide, but this is this is a front page to the process that we use to accept submissions or suggestions for new data elements in USCDI. We've been using this system now for the third year in a row, and anybody who registers on our website can go in and make a submission, add technical details, and we will consider everything, including comments on previously submitted data elements that maybe need to be reconsidered for addition to USCDI. Once we get hundreds of these submissions for additional data elements. Some of them are small details and some of them are bigger, broader concepts. But we look at everything, and amongst the ones that are most mature and feasible and readily implementable, we have to sort through them and prioritize. And we prioritize them based on technical criteria, as well as, and probably most importantly for this conversation, is what I call policy priorities. And those are things that HHS and ONC in particular feel like are the most important or more important sets of data. And those include things like addressing data that addresses healthcare disparity, the needs of underserved communities, behavioral health and public health reporting. The remaining 5 of those are more technical criteria so that we don't place too much burden on those who develop the standards, EHR providers or EHR developers who have to get the content into their EHRs, and then providers on the direct healthcare side who have to actually implement these into workflow. So we sort through all of the submissions and apply these prioritization criteria to it to come up with what we have in each subsequent version. When we first published USCDI, we already were looking at health data through an equity lens. Even prior to USCDI version 1, we had requirements to collect and exchange race and ethnicity data, preferred language, and then with USCDI, we introduced the concepts of patient goals and health concerns, which would begin to address those. In 2021, we introduced an additional set of data, including SOGI and SDOH data, along with expansions of the care team member, some of the details around care team members. And in version 4, which we published last July, we added a number of different demographic data elements, along with a set of health status assessments around function, disability, and mental or cognitive status. We also added some other ones that you might think of these as more tangentially related to equity, but things like health insurance and coverage, along with occupation and industry. In January of this year, we proposed draft USCDI version 4. We hope to publish the final after we've sorted through all the comments and recommendations. But we added a number of additional health status assessment to the draft, including alcohol, substance abuse, along with 2 sort of new areas of health data, at least from a certification standpoint. And that includes these 2 elements of patient goals around treatment intervention preference. So these are preferences around DNR, DNI, and those sorts of things, along with general care experience preferences as well. We also added data elements around medication reconciliation, including patients' reported adherence to their medical regimen. So this is a draft. This one is draft. There's some great things in it. We're working on the final, which, like I said, we hope to publish next. We will plan on publishing next month, barring some kind of catastrophe. And this is just a quick overview. Lot to read. They're in the slides. They're on our website. And these are some things that I felt like were specific areas where the contents of these healthcare data exchanges do address issues around health equity, and used in combination allows identification of equity risk, along with measuring and relating some of these risk factors or some of these equity pieces of data to outcomes as well. So by identifying it, recording it, some of these things, race and ethnicity, SOGI, and other things, even simple demographics like address, those can be compared to, measured against actual outcomes. So I feel like it's continues in that direction, and we feel like we actually, as the C part of ONC is coordination, and we have a responsibility to coordinate with other federal agencies and other stakeholders in the adoption of data policy. And we've worked very closely with CMS over the years of developing USCDI. We've gotten a ton of input from CMS. We've gotten a ton of input from CDC and a number of different federal agencies about the content for what should go in the next version. And we continue to work with them. We also worked closely with CMS to help inform some of the content in the recently published path forward to health equity data. And we're proud of the collaboration that we've had with CMS and hope to continue to do it to continue to advance the liquidity of health data, health equity data. And my number's on the screen, and feel free to reach out to me, any questions, either directly to me or through our through the USCDA website. Thank you very much.
Good afternoon, everyone. Can you all hear me? Okay, excellent. I'm not sure if there we go. Excellent. Hi, everyone. As Akin said, I am Lauren Ripplinger. I am the Chief Public Policy Officer for the American Health Information Management Association. And today I wanted to talk to you a little bit about, as I work the clicker, there we go. Okay. I would share with you a little bit about a survey that we conducted last year around the collection, integration, and use of social determinants of health data. Before I do so, I do want to share a little bit about who we are as an organization. AHIMA is a leading voice and authority on health information in the healthcare industry. We represent health information professionals that work with health data for over 1 billion patients a year. Our members are really focused on ensuring the accuracy and integrity of an individual's health information while making sure that information is kept private, confidential, and secure. So many of our members work as managers, directors, VPs of health information management, specialists in health IT, as well as medical coders. So that's a little bit about us. Our mission as an organization is to empower people to impact health. We partner with this work with NORC at the University of Chicago. Many of you all are very familiar with NORC, I'm sure, but they are an objective, nonpartisan research organization that delivers insights and analysis that decision makers trust. In terms of our key objectives, what we wanted to do as part of this survey is task NORC with a quantitative survey of health information professionals to really understand data collection and use of social determinants of health data. And these 3 objectives were really first around better understanding how is this information collected today, as well as coded and used. Second, to inform the development of educational tools and resources that are needed by health information professionals. And finally, to really inform the development of policy recommendations to further that standardization of SDOH data. So in terms of the survey itself and the methodology, this was a 27-question survey. We sent this to about 41,000 health information professionals. And again, wide variety of respondents that we had, VPs of HIM, medical coders, et cetera. And the sample that we received back was a little over 2,600 folks. And we fielded the survey at the end of August last year, early September. And it really focused on 3 key topics: data collection, data use and integration, and data governance. So what were some of our key findings that we heard? First, what we heard is that there's a lack of standardization and integration of this data into an individual's medical record. Second, there was insufficient training and resources around how do you capture, collect, code, and use this information. And finally, what we found from the survey results is that there's limited use of the data to communicate between providers and community-based referral organizations. And I'm going to take a deeper dive into each of these 3 findings. So first, let's talk about lack of standardization and integration of the data. What we found in the survey, respondents said that 78% of them said their organization does in fact collect this information. 22% said they actually did not collect the information. The main reason behind that was that their organization simply doesn't screen for this information. So what this indicates to us is that there is certainly an increasing awareness of the value attached to collecting this information in the first place. When we asked folks about how do they capture the information, respondents, 71% of those that do capture it said they mostly capture it electronically via their EHR. 2% said they do capture it electronically, but not through the EHR. We think this seems to indicate that they might have a data collection portal that they use electronically or some other homegrown electronic tool to collect this information. And then we had 5% said they collect this information verbally and 4% collected on paper. One of the things we heard when we think about collection of this data is that the prioritization of the different SDOH data elements is uneven across the healthcare sector. So health insurance coverage, health behaviors are historically widely collected. So that might suggest there's an increased likelihood that there are fields within an organization's EHR to easily collect this information. Of course, what we also found was that things like housing insecurity, food insecurity, transportation needs were at a much lower prioritization level. So one of these things that this might suggest is that there may not be a dedicated field within an organization's EHR. But even beyond that, we know there could be other reasons for why this information is not collected, including lack of incentives, or it just may not be, there might be competing priorities within the organization around the collection of this information. I want to talk a moment about screening tools. While certainly some of this information is collected by clinicians via clinical notes, we know screening tools is a common way to collect this information. What we found from respondents was that the CMS AHC core domain screening tools were the ones that were most frequently used. But as you can see, there's a large variety of other tools that folks said that they were using. What this indicated to us was that there may not be a singular preferred screening tool to collect this information, and that there was potentially an overall lack of awareness of what tools are actually out there that people can take advantage of. I think it's really important to note in the context of the screening tools, though, that many of these different screening tools have different structures and different focus areas. And so we know that, the screening tool you oftentimes use in the environment is going to depend on what your needs are as an organization, right? What works in a pediatric setting may not necessarily work in an adult setting. So I think that's important to call out. While there wasn't consensus around the domains or the screening tools, we did hear from respondents that there's overwhelming agreement that they use a standardized coding system to code this information. So 80% said they use a standardized methodology. Of those, 99% said they actually rely on ICD-10-CM in order to code this information. That said, what this data doesn't tell us is the frequency in which this information is actually coded and the accuracy and consistency of that coding of that information. In addition, the survey also found that many healthcare systems and organizations are collecting individual data elements, but they're not necessarily integrating it into their EHR. So when I say integration, what I'm talking about is some sort of integration process of that information into the organization's EHR, whether that's through manual processes or through some form of automation. So by way of example, if you look at the top, and I know a lot of the lines overlap, but if you look at mental health and health behaviors, 9 in 10 of respondents said that they do in fact collect this information at their organization. But when we ask the question of, do you integrate it into your EHR and your data warehouse, only 6 in 10 individuals said their organization actually integrates that. And there could be a lot of factors that limit this integration, right? It could be that the information is incomplete, it's unstructured, or it's buried in inconsistent fields within the EHR, such as health concerns, social history, and goals. The second challenge that was identified in the survey was around training and education for capturing and using this information. What we heard from the respondents is that frontline clinical staff are obviously tasked with collecting this information when a patient comes in for a visit. What we heard was that nurses were predominantly the folks that collect this information, followed by physicians, administrative staff, and social workers and case managers. What's interesting here on this graph is you see this 26% of unknown. They don't know who collects that information. And we think a lot of this is a function of where the respondent might sit within their organization. So for example, a medical coder doesn't know who necessarily documented it by the time the documentation gets to them. So we think that was one of the reasons why we saw this unknown pop up in this data. We also asked respondents about, what education and training do you currently receive to support the collection and use of this information? Folks said that, They certainly receive privacy protections and security standards training. They also receive training around the AHA coding clinic for ICD-10 CM and PCS, and for the guidance as well as the Z codes, right? So certainly they are getting some degree of support. That said, when we asked about what are your main challenges around collection of this data, 93% of respondents said that a lack of a trained workforce is their leading challenge in collecting this information, which to us tells us that there is more training and education that's needed to really help educate that care team who's collecting that information. Other reported challenges included lack of organizational policy, patient distrust, and inability to address those social determinant of health needs. Looking at the flip side or the other side of the coin on that, we asked questions around what are your challenges around coding this information? 83% of respondents said, again, staff training is one of their main challenges, which again suggests that current training and education and resources are not sufficient around this work. What's interesting is that 78% said they couldn't find the information in the record. What we think this suggests is that operations staff may know the documentation requirements to code, but they may not necessarily, the information is not readily available. It's not very apparent within the documentation, or what we've also heard is they may not have access to that portion of the record in order to actually code for that information. The last challenge that was identified as part of this survey is really around communication between providers and community partners. So we know addressing social determinants of health is not something that can be done by any one organization. And so it's really important, just as much as we focus on the collection side, it's really about building those channels between the provider and the community-based organization. Unfortunately, what we found is that the communication and integration between providers and social service organizations is often limited and inconsistent. And when we ask the question of how do you actually use this information within your organization, respondents said 32% said that it's for patient referrals to community-based organizations, followed by the ability to identify and assess community-level needs. Finally, when we asked about whether do you make electronic referrals to community-based organizations or referral partners, 82% said yes, they do, but they're less likely at 64% to actually have a closed loop referral process, which we know is so critically important when we're talking about whether or not the physician knows that the patient's needs were actually met. So this survey is just really the first step in terms of AHIMA's new effort around data for better health. And this is really an initiative around increasing awareness around how collecting, using, and sharing this data can really improve individual and community health and healthcare outcomes. So over time, we're going to be releasing tools, resources, and education that will help address the concerns that we identified in the NORC report and better support healthcare professionals at large to build this business case for the collection and analysis of this information. So we'll be offering tools and tips and strategies of success related to the collection, sharing, and use of this data to maximize impact. So if you're interested in learning more, I have the website up here on this page. You can also sign up to receive updates about the initiative. And I'll also add, we are looking for partners and collaborators in this work. We cannot do this work alone, and nor can providers and hospitals and payers. And so if we're really going to move the needle in terms of advancing this work, we need to work together. So I encourage all of you, both here and online, if you're interested in partnering or you want to share a social determinant of health story, I encourage you to contact me at my information on the slide. And thank you all for your time today. And I'll pass it to the next panelist.
Righty. Good afternoon, everyone. All righty. So I'm Samantha Richardson. I am the Director of Governance and Impact Analysis in the Office of Burden Reduction and Health Informatics. And if you're familiar with CMS, everything's an acronym. We call ourselves OBRI. Okay. So let's see. So let me tell you a little bit about OBRI, first of all. So we were created in 2020. And let me tell you what we do. We look at the healthcare enterprise across CMS. We look at reducing inefficiencies. We look at how we can utilize technology, policy, and innovation to do that. So within my group, we look at innovation. We look at evaluating policies to see if they're more burdensome to both patients and providers. Our goals are very specific. We infuse the customer perspective. That means that we are constantly talking to our stakeholders, providers, patients, organizations, hospitals, et cetera. We look at innovative solutions. So for example, within our organization, we're looking at outdated regulations, outdated policies. We're using AI technology to do so. Additionally, we're advancing standards and interoperability, and we're advancing health equity. So today, Raina and I will be focusing on two different tools that we're using to ensure we hear the voice of the stakeholder, our customer. So one will be a provider survey, and this one that I'm going to talk about, which is a Make Your Voice Heard, RFI. Now, if you guys have heard of RFIs from the government, typically there's one way: you write a letter, you do a letter writing campaign, you send that information in, it goes into a database, we review it. So we said, okay, let's do something a little different. Let's make it a little bit more innovative. So we developed a web-based portal so that you can enter the information and it automatically comes to us in a database. What was really unique about it was that you could go and get the link and send it to your patient, your parent, your brother, your sister, whomever, and you can put the information that we're asking about right into this portal. And you can well, right now, if you go to our website, you'll see some of the high-level information that we received. So it's a tool, it's a way to learn more, get more information real time. We focused on patient experiences with accessing healthcare, and especially within CMS, Medicare, Medicaid programs. We looked at provider experiences throughout the healthcare system, and also asked questions about considerations for advancing health equity across the healthcare system. That's what we'll focus on today. And additionally, we asked questions about the impact of COVID-19 and the unwinding of the PHE. Okay, thank you. So what did we learn about health equity? So I was just talking with Dr. McGeever in one of the other rooms over there. And I said, you know, it's really striking information. And to be quite honest, because it impacts me, my family, and folks that I know really on a personal level, it was difficult reading the comments. And these are, you know, real people. These are consumers, our customers that we serve. But I totally felt the responses that we learned. So the commenters emphasized the importance of health equity in all aspects of care. Okay, what does that mean? That means we're looking at inequitable healthcare system design. We're looking at many stories about existing biases and inequity in healthcare experiences, limited reimbursement in underserved areas for providers. And there was significant sharing of information about challenges with trust, the lack of patient trust of the healthcare system, which is attributed to discrimination and history. And we'll go a little bit further into that as we move forward. So what you'll see on some of these slides is a lot of information. The little beige box are the actual quotes that we received from our respondents. So for this one, we're looking at inequitable healthcare system design. So we received many comments that stated, CMS needs to do better, basically, is what they're saying. They highlighted that inadequate training around culturally competent care is an impediment to high quality care for many people in our society. Many comments that we receive focus on inequities in the design of the overall healthcare system. This includes comments about patient barriers to accessing healthcare. Implicit bias is something that many of the respondents spoke of as well. So from an organization, the healthcare system as a whole needs to address implicit bias and institutional racism first before looking to the role of social determinants of health. I hope to hear from many of you of how, you're doing that or how we should do better. Bias and inequity experienced in healthcare settings. Commenters noted the importance of proposed updates to non-discrimination protections that have been proposed by the department's Office of Civil Rights. They also supported increased investment in training healthcare providers serving underserved communities. Respondents highlighted the potential for biases stemming from algorithms and artificial intelligence. And finally, many expressed concerns that ongoing staffing challenges might also exacerbate health disparities. So one caregiver or patient, we didn't put anyone's name in, too often, those of us who live in a more remote area do not have access to the same benefits as those who live in town. Yeah. Have you ever traveled anywhere and you're kind of like, oh my goodness, where would I go if something happened, but you have insurance or you have transportation? We were told someone would call back, and it took almost 4 days, and my mother died. We have to do better. There's also limited reimbursement for providers serving minority or underserved populations. So the respondents indicated that inadequate pay parity across provider and facility types, along with payer mix, exacerbates existing health disparities and limits patients' access to care. So I'm currently one of the respondents. I'm currently unable to accept Medicaid because of the barriers related to credentialing processes and also to the extremely low pay rate. So what do you do as a provider when you want to go and you want to work in an underserved location? And you still have medical loans or bills you have to pay as well. And then my colleague mentioned trust, and that is a common theme. So there's historical breaches of patient trust. Mistrust is at the heart of a lot of the issues. They stem from both historical, societal, or individual experiences. I mean, I know I have a little kid who, you have your kid and you say, don't touch that stove. If you touch the stove, you're going to get burned. Don't touch the fire. And then they learn from that, right? So they know they're not going to do it again. So it's challenging if I go somewhere and I feel like I have been treated differently than my colleague to go back. What's the motivation, right? So commenters noted that this lack of trust can also have downstream impacts, such as an increased unwillingness for patients to disclose self-reported demographic data, which can create challenges for developing interventions to address health disparities. So we're trying, what do we say here? One of the comments states, empowering our non-traditional community-based partners to align with the health sector is key to addressing social determinants of health across the continuum from birth to adulthood. So I know that within CMS, we definitely are partnering more frequently with the community-based services and churches and D9 organizations and the such, but we need to do more, and we all need to work together to accomplish that. So As we diffuse the data across the CMS enterprise, what we're looking for is true policy change, because we're talking about health equity and disparities, but to really see the change, it has to become a part of our policy making. So part of what we do as an office is we share the real-time data with our colleagues across the enterprise. What I'd like to do is now bring Raina up to talk about another tool that we've utilized to learn more about the provider experience.
So good afternoon, everyone. Okay, let's see. No, yes, no, maybe so. Is it not? Now it doesn't want to work for me, right? Everybody else got it. Hey. Where? I am hitting the green. No. There we go. Okay, there we go. Or maybe I wasn't. Okay. I have no problem saying when I've made a mistake or I'm wrong. So good afternoon, everyone. My name is Raina McLean, and as Samantha mentioned earlier, we work in OBRI, OBRHI at CMS, and I am going to talk to you all about the second opportunity that our segment was able to get some feedback from our customers. So as you all know, over the past 3 years, the healthcare sector has had some significant changes as a result of the COVID-19 public health emergency. And so there's been a renewed focus on health equity and making sure that patients, providers are able to access the services and the benefits that they need. So what we wanted to do was to find out how the changes in the healthcare system have affected providers, and specifically those who served underserved communities. So in an effort to gather that information, we not only submitted the RFI that Samantha provided information on just moments ago, but we also created a survey that would focus on some key topics. And these topics were patient challenges utilizing video-enabled telehealth, as well as provider screening for and addressing patients' social needs and risks. And interestingly enough, when Lauren was presenting earlier, I'm sitting there, I'm like, she stole my slide. She stole my slide. And we have not worked together before, but it's just very interesting to see some of the similarities in each of our works. So when we released the survey, we asked questions about the use and perceptions of scope of practice flexibilities during the public health emergency. And so all of those things that I just mentioned are things that I'll be discussing moving forward. Green button. Okay, so here is an overview of the fall 2022 data collection that we put forth. So we developed the survey to focus on provider perceptions as they related to the specific patients that they serve. We wanted input from office-based providers, and we defined those as providers who saw at least 35 patients a week, and that they were seeing Medicare and or Medicaid beneficiaries. We surveyed primary care physicians, OBGYNs, pediatricians, nurse practitioners, and physician's assistants. So with the survey data, we did conduct a subgroup analysis in order to compare responses between providers that served underserved communities and those providers who did not. And the way that we defined underserved communities was by looking at the area poverty level, which we used the area deprivation index. We looked at racial and ethnic composition of the practices patient population, as well as whether the practices were in rural locations. So today's presentation will focus on the findings mostly of our subgroup analysis as related to the area poverty level, as well as the racial and ethnic composition of the providers' populations. And what we really wanted to know was the insight on whether and how provider burden and experience varied across the different populations. So first, we'll talk about access to video-enabled telehealth. So we have the bar graphs here on the chart. And what I'd like to draw your attention to is towards the bottom, we asked providers what they felt were the top challenges that their patients faced. And again, we were not speaking to patients, but these are just provider perceptions of what they felt about the challenges that their patients felt. And you can see at the bottom where we have limited experience and comfort with technology. When we started going into the study and asking the questions, we had some preconceived ideas about what we thought would be some of the challenges and where we might find those challenges. And as you can see, we had 82% of patients that lived in low poverty experience limited experience or comfort with technology, which was surprising because we thought that we would find a higher number in terms of patients that lived in the higher poverty area. And as you can see, all of the numbers are very similar and close. And so that result was not considered to be statistically significant. The other thing that I want to draw your attention to is the fact that for those who lived in the highest poverty areas, their top concern was bad or unreliable internet. And that's something that we did feel was, that did lend itself to the hypothesis that we have. But again, 74% bad or unreliable internet for those highest poverty areas. The next slide looks at the use of audio-only telehealth. Just a reminder, the slide previous was for video-enabled telehealth. Now we're looking at those patients who are not looking at their providers via a smartphone device or through the computer. This is just picking up the phone and talking to your provider. And what this chart shows is that the percentage of providers that reported more than 60% of their patients used audio-only telehealth across the practices, racial and ethnic composition subgroups. More practices in the high and the low groups reported that more than 60% of their patients used audio-only telehealth, which is very telling because, initially a lot of the concern was how are we going to make sure that we speak to our patients? How are we going to make sure that we see these patients? But you can see that the audio-only telehealth is a huge advantage for providers, for patients who are not able to have that reliable internet service or who may not be as inept at using a smart device. So the audio-only telehealth is really a huge benefit to those patients who are underserved. The next thing that we looked at was the provider's screening and perception of the patient's social needs. And so this is where I was looking at Lauren's slide and I said, oh, see, she's stealing my thunder. But when we did our survey, what we saw was that of those practitioners and practices that do screen, there's no commonly used instrument. There are a number of instruments that are out there. And what we did see, just as Lauren saw in her analysis, was that the CMS Accountable Health Communities tool is the most utilized. One thing that's very important here is the fact that because there are no standardized screening tools, again, there's so much variability in the questions that are asked, what's done with that data, how is that data utilized? And so it would be, it would be beneficial and helpful if there was a more standardized tool that could be adopted to gather this information. When we looked at practices in the highest poverty area, they were the most likely to use the data for external coordination. So if you look at the chart, there is a relationship between the poverty level and the likelihood of having patients being coordinated with community organizations. More providers practicing in the higher poverty areas said that they used the data to partner or coordinate with organizations in the community as compared to providers practicing in the lower poverty areas. So when those social determinants of health needs are screened for, we are seeing the ability for providers to connect their patients with the services that they need. But again, there should be more consistency across the board. So I just want to wrap together some of the information where we saw some consistencies across the RFI that was put out as well as the survey. These were the two ways that we were able to engage with individuals and with stakeholders, and the insights from these activities can help frame the future of equitable healthcare. So the survey results showed differences in terms of the patient populations among providers serving underserved communities. These insights do underscore that there are systemic differences that may create disproportionate burden, not only to providers, but as well as to patients. And we want to be able to mitigate the burden. The survey results did suggest that telehealth, particularly audio-only telehealth, is very important to providers that serve those underserved communities. If we think about it, when Samantha was speaking about not having the healthcare services you need because you live in a rural location, what was one way that patients were able to get in touch with their doctors during the public health emergency? It was through telehealth, whether it was audio or visual. So that's really important. And it also suggests that beneficiaries in high poverty areas and rural communities, again, would benefit from these services. And finally, we also found that though many providers indicate that they collect social needs data, many are not using a formal tool. There was no leading tool identified, though the CMS one was the top performer. But again, we also have some practices that are using their own tool, just asking those questions, getting the information from the beneficiaries. And in response to the RFI, we did receive several comments about the need for increased data collection and establishing a standard. So again, just consistency between the survey, which was multiple choice, and the RFI, which was open-ended. And ultimately, the emphasis is a need for a universal collection and standardized data element to ensure that data does have integrity and value to both providers, patients, and CMS. So overall, the RFI and the survey generated valuable insights on provider experience related to equity. Our subgroup analysis enabled us to tease out the unique perspectives of providers who serve underserved communities. And understanding these differences and the context will help us to ensure that these perspectives are continued to be heard. And we will be working to have future opportunities for engagement. Thank you.
All right. Well, let me invite the panelists up to the chairs here for our Q&A session. That was a lot of incredibly rich and valuable information that I know they covered. So let me open it up to the room first to see if there are any questions. You, sir.
A couple of items here from Oklahoma. A lot of talk about social determinants of health. I've been hearing various places start to call it structural determinants of health, so that it doesn't seem like it's social decisions of people being made, not as soft. So I'm wondering whether structural determinants of health is becoming common elsewhere. Now that social determinants of health is a billable event, doing the survey, and it's getting into the EHRs, part of the concern is that this is going to get used to lower goals. In other words, if a health system or provider has gotten someone's A1C just to 8, but that person has 3 social determinant of health points, maybe that's okay. Any sense that social determinant scores are getting to be used as a mitigating factor for why somebody still has high blood pressure after 2 years of treatment, things like that? Thank you.
Any of the panelists want to offer a couple of perspectives there?
Can you hear me okay? I wanted to address the question about does a social determinants of health risk sort of reduce the standard of care. I think that from my perspective, the way that social determinants of health ought to be used as sort of a trigger for additional screening, a trigger for a particular pathway in care. And so the pathway in care for, say, diabetes is to reduce A1C below 7, or whatever number that you pick for your practice, or identified by other practice guidelines. So I don't see that. I don't see that as changing the rules. I just think it as an opportunity to alert for the need to provide more directed care. That's my take on it.
All right. Other questions in the room? Yes, ma'am.
Hi, Claudia, CMS. We're writing a rule here on cultural competency of health. I had a quick question because I'm tasked with writing the economic analysis of it. Did you, on your survey, did you have anyone who talked about the time, additional time to pick up this collection? Any insight on that?
So I can answer. Folks hear me okay? Okay. We did not ask that question. However, I will say what we anecdotally know, particularly on the coding side, is that oftentimes there's a disincentive to document the information because it goes against the coding productivity standards that organization might set. And so I think that just goes to the larger question of how are we making sure, and I can say this as the non-federal partner here, right? That there's incentives in place to encourage the collection of this data. Because I think what we hear a lot of times is we have so many things to do in a day that affects our reimbursement. And sometimes this just doesn't rise to the level of priority that it should within an organization.
All right. I know we have some folks who are logged into the live stream of this as well. Are there any questions from there? And then we'll go back to questions in the room.
Yes. Sylvia has a question for Aubrey. How can we ensure that the disparities and barriers experienced by people with disabilities are captured by healthcare quality and equity surveys?
Can you hear me? Okay. That's a really good question. What we are doing is taking the data that we've received and spreading that information throughout our policy arms. So the goal is to see those changes reflected in our regulations and our policy. So definitely for Sylvia, she would have to keep, talking to us. We want to engage, we want to partner and get that real information.
Other questions in the room? Let's see. I think we had you, sir, then you, ma'am, and then you, ma'am.
Michael, the
Good.
reverberation. Michael Greer, NCQA. You talked about there isn't a predominant social screening tool. And so how do you all plan to kind of move towards or encourage more providers to be utilizing a more unified social screening tool without kind of increasing that burden or kind of driving and still allowing, again, organizations to have their own autonomy in their work and in their operations? I know we can do it through EHRs, but is there some more thought that's going in around how we can get that information in a more consistent manner that you all are putting in place?
I felt you looking right at me to give you the answer. So right now, we don't have a distinct strategy to do that. What I will say is that we have a follow-up survey that will be going out and we are developing questions. So based on the feedback that we got from this initial survey, we will be sending an additional one out to providers to ask more about whether there are, if they desire more educational opportunities from CMS, more guidance on how to use specific tools or, reference points. So we want to get that feedback, to find out what is it that you feel would be most beneficial to help you in gathering this information, sharing this information, making sure that information is interoperable. So that's definitely something that we'd actually like to get the feedback because again, we can put something out there and it may be more burdensome. And that's not what we want to do. So asking that question to the stakeholders is what the next target is for our upcoming survey.
Okay, I think we had the.
My question is around understanding data trends. So looking at some of the survey results from both of your presentations, wondering if there's a strategy in place for follow-up. So in an increment of time, like the next 5 years or the next 10 years, how would someone who's interested in seeing whether or not policy interventions are influencing that data to go up or down? Is there any plan in place to repeat these surveys or studies?
Okay, so again, the next survey that we are looking to release, so our survey was done last August through September. We are looking to have a longitudinal survey that will have the additional questions released again this August through September. Again, for the providers to see if there's a change in some of the perceptions, some of the answers. What we also want to do is release a survey to patients, because we can get this information back from providers. That's their perception of what the patients are going through. But now we actually want to know from the patients in those same or similar type underserved settings. So that's where our longitudinal program is trying to go, look at the questions from last year, add those plus some additional, and then also do that research with the patients.
Lauren, do you have any plans for follow-up surveys?
So we are definitely talking about it internally. The other thing is we came out of that survey with a lot of additional questions that, I mentioned today, and other things we're thinking about as we have conversations with different stakeholders. And so that's kind of where we're at right now is can we do some follow-up questions to some of this audience to better get a little bit of a deeper dive in terms of what's going on of the unanswered questions that we came out of that survey.
And then in addition, we do intend to release another RFI. And we try to make the questions very relevant to what's going on. Then within my group, we do the back end. We look at, you asked for this, here's what we did. Maybe it hasn't happened, or why has it happened? Then eventually we'll be public facing response.
So I know we had you in the back. I think, unfortunately, this may be the last question we have time for.
Thank you all very much for your presentations. They were all very good. This is a question for Lauren. One of the resources I'm wondering if one of the resources that your organization might be coming out with is training on social determinants of health, how to collect those data.
So I'll take because we represent health information professionals, we would probably focus our training around specifically them and kind of the role they play in the conversation. I think this goes back to kind of the end of my presentation. We don't, we recognize that we are not going to be the authority, right, in terms of all of these. And so I think for us, when it comes to if it's collecting, if the nurse is doing it, if it's the provider, we want to partner with those other organizations that truly can speak with that provider voice to a much better extent than we can because we represent that health information professional. Does that make sense? Mm-hmm.
All right. Well, a big thanks to our panelists for sharing their work and their perspective and expertise with us this afternoon. And thanks to all of you for your questions, and thanks for those of you who tuned in via the live stream. I guess we're on to the next session. Thanks so much.